Okay, good afternoon. I'm going to be talking about a clinical trial. I'm the PI for it. It's called the Trifecta study. It's a triplet immunotherapy study for recurrent head and neck cancer patients. So, as we know, patients with recurrent head and neck cancer have really a dismal survival. They have really few options available to them. They've exhausted all surgical, all radiation, all standard chemotherapy options. The new standard of care for these patients is often one of the two FDA-approved PD-1 inhibitors or immune checkpoint inhibitors, nivolumab or pembrolizumab. And while we see results and responses with these response rates, durable response rates, are quite low, on the order of about 12 to 20%. So why are they so low? Well, these tumors have found ways to evade the natural host immune system. And two of those ways they do that are to binding to the PD-1 receptor on the T cells, which decreases the T cell survival as well as T cell proliferation. And secondly, they decrease the antigen presentation to the T cells, so they're not recognized by the T cells in order to kill them. The way anti-PD-1 or immune checkpoint inhibitors work is by binding to this PD-1 receptor on T cells, and pretty much they're taking a T cell that's been held in check and allowing it to do what it's supposed to do, and that's attack and kill that tumor cell. There are some prerequisites for a response to immune checkpoint inhibitors, two of those being infiltration of T cells into the tumor, as well as antigen presentation of the tumor cells to the T cells. And this creates a hot tumor microenvironment as compared to that cold tumor environment where the PD-1 is bound to the PD-1 receptor. One way to create a hot tumor microenvironment is with IL-12. So interleukin-12 is a potent pro-inflammatory cytokine that induces a hot tumor microenvironment through a variety of mechanisms. The issue with IL-12, though, is you can't deliver it systemically. It's quite toxic. However, we found a way to deliver IL-12 directly to a tumor, and that's with this medication called tavokinogene telsoplasmid, which is a plasmid that has a DNA promoter region for IL-12. And what happens when you inject this into a tumor and electroporate it, which I'll talk about shortly, the tumor itself is producing IL-12. So you get the local benefits of IL-12 without the systemic toxicity. So how does this work? So this TAVO-EP is an invention of a medical corporation. It's really the main basis for this Trifecta study. So what we do here is, if you look down at these points, the first part is to inject the tumor with the TAVO or the IL-12. The next part is to electroporate it. So what is electroporation? Electroporation pretty much is delivery of electricity, which induces the cell membranes to open up, so this IL-12 plasmid could then go into the cell, gets transfected, and then the tumor cell itself will secrete IL-12 within the tumor microenvironment. And again, you get the local benefits of IL-12 within the tumor, you get systemic benefits as well without that IL-12 systemic toxicity. This plasmid is really the key here. It's unique in that you get exposed IL-12 exposure within the tumor as opposed to a transient exposure if you were just to inject it directly into the tumor without it being transfected. And of course, again, the systemic effects if you were to inject it IV. So this TAVO-EP has been used by one of our colleagues, Dr. Alan Alghazi, medical oncologist, for quite some time in melanoma, and we used it in a pilot study for head and neck cancer patients. We noted that the patients tolerated the injections well. We noted that when we looked at the specimens, there was sustained IL-12 within the tumor. And then most importantly, patients responded, 34% response rate just doing this alone. If you add it to Pembro, that response rate went up to 50%. And remember, the normal response rate for Pembro alone is around 12 to 20%. It was these studies that prompted this current trial, the Trifecta study, which is the combination of the tavokinogene or IL-12 and electroporation, the Pembro, and then we added a third immunotherapy medication, which just increases T cell populations. Here's the objectives. We wanted to see if this triple combination therapy was better than pembrolizumab alone, and secondarily, obviously make sure we're safe and see if these responses are durable. This is our trial design, what a patient would go through. They're going to receive pembrolizumab at the normal schedule every 3 weeks, epacadostat daily, and then I'm going to be injecting these tumors with the IL-12 plasmid and then electroporating them on days 1, 5, and 8 every 6 weeks during their trial. So we're very excited about this trial. It's a wide open study. We're accepting patients with squamous cell carcinoma from any subsite, any prior treatment history. Really the only thing they need is confirmed recurrent disease, and most importantly, a tumor that's accessible for me to inject and electroporate. So if you have any patients who would benefit from this, please reach out to me. Thank you.